Good morning, guys. Coming to the part two of jaundice. So, in the first part, we looked about how the RBCs are broken down, how your bilirubin is metabolized, and what it is excreted, and all those things. And in this part, we are going to look about the various types of jaundice and what you see in each jaundice. Fine. So, if you looked at the first part, this will be very easy. Fine. Okay. Now, you know that your bilirubin is going to get conjugated to the albumin, which then enters the liver, and then it conjugates with a specific enzyme. We call it as UDP glucuronide transferases, and then it enters the hepatocyte with the help of certain transporters, and it enters the biliary system, and it is obviously going to get converted to stercobilin and urobilinogen, and it is going to get excreted via our kidneys. Okay. Now, what happens if one or two of the pathways of which your bilirubin is going to get excreted is not going to function? So I'm going to list them. Okay, so the first one is going to be increased Emo Lysis. The first one what you are going to talk about is increased Emo Lysis. So what happens in increased Emo Lysis? Your bilirubin is going to get increased, so your liver says, no, I have exceeded my limit and I cannot convert all of those. So what happens? It is going to enter the blood, and ultimately it is going to cause hyperbilirubinemia. Okay, the second defect is, what if your bilirubin is normal but your liver says, okay, I'm not going to give entry to all of the bilirubin, to any of the bilirubin, so I have the defect here. So there is an decreased hepatic uptake. There is a decreased hepatic uptake. Okay, now what if there is a defect in UDP glucuronide transferase enzyme? Fine. So your bilirubin is normal, your liver accepts the bilirubin, but your UDP glucuronide transferase says, no, I will not conjugate it. Fine. So you have the defect in conjugation, decreased conjugation. Okay. Now, if there is no defect in these three, what if there is a defect in the specific transporter into the biliary system? Because it is present within the liver, I call this as intrahepatic obstruction, intrahepatic biliary obstruction. Fine, I call it as intrahepatic biliary obstruction. Okay, now all these are good, but at some point of my biliary system, either at this duct or any way along the biliary system, it is going to get obstructed. Then that I call it as extrahepatic, because it is present outside the liver, right? So I call it as extrahepatic biliary obstruction. Fine. So you have the 5 basic ways in which your bilirubin is going to get increased, isn't it? So if you look at the first 3, your increased hemolysis or decreased hepatic uptake or decreased conjugation, you are going to get predominantly of unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia. On the other hand, if you have your intrahepatic obstruction and your extrahepatic obstruction, for example, my defect is here and here, so the problem is not in my conjugation. So obviously my bilirubin is going to get conjugated. I am going to get conjugated hyperbilirubinemia. So this is very, you can easily correlate it. Okay, all these takes place. Now, if you look at the causes of this hemolysis, the first one, your hemolysis, if you see, it can be intravascular or extravascular. As I said, if it most commonly occurs in your spleen, we call it as extravascular, and intravascular hemolysis can also occur. So, in certain diseases like, your sickle cell disease, your thalassemia, your ineffective erythropoiesis, in all those conditions, what happens? Your RBCs are going to get broken in a huge numbers. That is that is excess than the normal. So what happens? Ultimately, your bilirubin level is going to be increased. Okay, what are the conditions? You're obviously, as I said, your bilirubin goes and bind with your protein that we call as ligandin, isn't it? So if I have some problem in my ligandin, I'm going to get my unconjugated bilirubin circulated in my bloodstream. If my bilirubin is absolutely normal, and your uptake is good, okay, now what if there is a defect in my UDP glucuronidase transferase enzyme? So what happens, I'm going to classify it as two ways. One is my acquired, fine, one is my acquired, and the next one is going to be inherited, fine. So acquired, it can be because of the drugs, fine, or your hepatitis or cirrhosis, fine. So inherited is very important because it can be mild, moderate, or severe. So in a mild case, we call it as Gilbert syndrome, fine. If I have a deficiency of my UDP glucuronidase transferase where your bilirubin is not going to get conjugated, or if there is an defective UDP glucuronidase transferase activity where my conjugation is not that effective as I wanted, we call it as Gilbert syndrome if it is mild. And what if it is moderate to severe? We call it as Crigler-Najjar syndrome. Crigler-Najjar syndrome. Okay. In Crigler-Najjar syndrome, if it is very severe, we call it as type 1, and if it is moderate, we call it as type 2. Clear? So you have your UDP glucuronidase transferase activity. So where there is a defective conjugation, as I mentioned here, there is a defective conjugation. So whenever you have defective conjugation, you have your acquired causes and your inherited causes. So your inherited causes will be your mild, moderate, and severe. Mild is your Gilbert syndrome, and moderate and severe will be your Crigler-Najjar, where your type 1 Crigler-Najjar is severe and type 2 is moderate. Okay. Now imagine if my bilirubin is normal, my uptake is good, my conjugation is good, and what if my transfer to the biliary system, especially it is within the liver, so your intrahepatic obstruction is there. So what will I do then? What are the causes? So if you look at the intrahepatic, the same way I am going to divide it into your acquired and inherited. Okay, so in the I'll do it acquired and inherited, where you have your intrahepatic biliary obstruction, isn't it? Intrahepatic cholestasis. Okay, in this again I am having acquired and inherited. In the acquired is very simple, it's your viral hepatitis or drugs, your cirrhosis, all those things. Okay, in my inherited, if you see, in my inherited causes, I call something called as Dubin-Johnson syndrome. Dubin-Johnson syndrome and Rotar syndrome. You can remember it as Dr. DR. So Dubin-Johnson and Rotar syndrome, it is one of the inherited causes of your intrahepatic cholestasis or intrahepatic biliary obstruction. So this where your bilirubin is conjugated, but it is not entering in my biliary system. Okay, what if there is a defect in my biliary pathway? Fine. So for example, I have a gallstone, there is obstruction of my gallbladder. So what happens if I have my tumor in my head of the pancreas? Okay, what happens if there is a tumor of my bile duct? Or in case of sclerosing cholangitis, in case of a chronic inflammation, ultimately your chronic inflammation is going to be healed by fibrosis, so there is a sclerosis of your bile duct, so I'm going to get sclerosing cholangitis. So see, basically you see your extrahepatic, any problem with your biliary pathway, that is going to cause my extrahepatic cholestasis. Fine. So now I'm going to tell this intrahepatic and extrahepatic obstruction as obstructive jaundice. Fine, I call it as obstructive jaundice. And this from the bilirubin from the increased Emo Lysis till it reaches the liver. Fine. So from the increased Emo Lysis till it reaches the liver, that is the first one, I call it as Hemolytic Jaundice. Hemolytic Jaundice. And since it occurs before it reaches the liver, isn't it? My breakdown occurs in my blood. So what happens? I am not reaching the liver. Before that itself my defect arises. So I call it as pre-hepatic. Fine. So hemolytic or pre-hepatic jaundice. Okay, now what if there is a decreased hepatic uptake or decreased conjugation, and these two I call it as hepatocellular jaundice. Hepatocellular jaundice. Okay, and this I am calling it as obstructive jaundice. Okay. 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 Now, if a patient comes to the hospital, is having hemolytic jaundice or hepatocellular jaundice or obstructive jaundice, so how we can diagnose the patient? Okay, so before moving into that, I will tell you a specific enzymes, okay, which will be present in the liver. Okay, if you look here, if you closely look here, you have your two enzymes. What are they? They are my AST, aspartate aminotransferase, your ALT, fine. Your aspartate transaminase and alanine transaminase, fine. AST and ALT levels, and you have some enzymes in your biliary system. What is this? I'll use another color. This is my, what is this? This is my alkaline phosphatase. Fine. So you have certain few enzymes also, which will be secreted by the liver, but will be predominantly present in my biliary system. I have two other enzymes. What are they? I'm going to call those enzymes as gamma glutamyl transpeptidase and 5-nucleotidase. Okay. Now recapping. I have some enzymes present in my liver. I call it as aspartate transaminase, alanine transaminase, AST and ALT, and a few enzymes present in my biliary system, your alkaline phosphatase, gamma glutamyl transpeptidase and 5-nucleotidase. Okay. If I have, okay, now coming to the hemolytic jaundice. As I said, hemolytic jaundice can be because of either sickle cell anemia, thalassemia, or ineffective erythropoiesis. There is an increased breakdown of RBCs where your liver cannot cope up for that. We get hemolytic jaundice. Okay, as I said, your hemolytic jaundice will be predominantly of unconjugated hyperbilirubinemia. Okay, I have an increased RBC destruction. So what happens? Ultimately, my hemoglobin is going to get decreased. The first finding what I see. Okay, sir, hemoglobin is decreased. Okay, now what happens is, as I said, there are two types of hemolysis: intravascular hemolysis, extravascular hemolysis. Extravascular hemolysis we can find it as easily as you will have a splenomegaly, because as I said earlier, your RBCs are going to get destroyed in your spleen, so that's the inflammation of your spleen will cause your extravascular hemolysis finding. So if you look at the intravascular, it can be your RBCs are going to get broken, so it releases increased amount of hemoglobin in my blood, isn't it? So what happens? I'm going to get hemoglobinemia. Fine. So what happens whenever this happens? A particular protein from my liver, eptoglobulin. So what happens? This eptoglobin is going to bind with this hemoglobin so that it traps the hemoglobin. Fine. So what happens once this happens? It can occur in two phases: acute or a chronic. Fine. This can occur in intravascular, can occur in acute or chronic phase. If you look at the acute phase, you will have definitely your hemoglobin is going to get excreted via your kidney, so I'm going to get hemoglobinuria, as well as it is toxic to the my proximal convoluted tubule, so I'm going to get acute tubular necrosis. Okay, so you're in the chronic type, obviously I'm going to get hemoglobinuria. In addition to that, what happens? Your iron in chronic type, your iron in the hemoglobin, what happens? It is going to be your iron in the RBCs and your hemoglobin, they are converted to ferritin, as I said before, with the help of an enzyme apoferritin, and they are stored as hemosiderin. So what happens? Hemosiderin I'm going to get hemosiderin. So I'm going to get hemoglobinemia and acute tubular necrosis in acute conditions, and in chronic conditions I'm going to get hemoglobinuria and your your increased level of hemosiderin in the urine, hemosiderin. Okay, fine. As a result, I'm going to get a decreased hemoglobin in my blood. Okay. The next finding what I'm going to see is decreased RBC, because my RBC are going to break down more. So I'm going to get decreased RBCs. What happens once your RBCs are getting destroyed, my bone marrow is trying to compensate for that. Fine. So I will have increased reticulocytes. And as well as I will have some macrocytosis. Your shapes will be increased. So macrocytosis. And now it will be very easy for you to answer. Will my AST, ALT, your alkaline phosphatase, gamma glutamyl transpeptidase, 5-nucleotidase is going to get increased? No. All these enzymes are normal. Your ALT, your AST, your 5-nucleotidase and your gamma glutamyl peptidase, all these are normal. Isn't it? So and one more thing is there is excess of urobilin. Fine, there is excess of urobilin. Okay, urobilinogen is increased. Okay, this is what I can see in my hemolytic or pre-hepatic jaundice. Okay, so patient will have a decreased hemoglobin, decreased RBC, increased reticulocyte, macrocytosis, all my enzymes will be normal and urobilinogen will be increased. Okay, now coming to the hepatocellular jaundice. Okay, now the bilirubin defect in my uptake of my bilirubin. So I have some ligandin dearranged within my liver, so I am going to get this type. Next, what are all the things I can see in hepatocellular? As I said, whenever your liver is getting damaged, you will see certain amount of enzymes, especially your AST and ALT. Definitely they are going to get increased. Okay, once again, your AST and ALT, they are definitely going to get increased. Your ALT and AST, they are definitely going to get increased. Fine. So what happens to your gamma glutamyl transpeptidase and 5-nucleotidase? They are mildly elevated. Gamma glutamyl transpeptidase and 5-nucleotidase, they are mildly elevated. And definitely there is not going to be signs of hemolysis. No hemolysis. Isn't it? There is no hemolysis. At the same time, there is no future of, increased erythropoiesis. Fine. So I cannot able to see my reticulocyte or macrocytosis. So there is no increased erythropoiesis. Fine. Okay. My total bilirubin level is going to be increased. In that, what is going to increase? My unconjugated bilirubin is going to be increased. And my conjugated bilirubin is also going to increase to a certain extent. Fine, because there is only defective. It will work, but it is not that efficient to convert all the bilirubin to the stercobilin and urobilinogen. Fine, you're clear with this. Okay. What will be the trademark diagnosis? I can say that it is an hepatocellular jaundice. My liver enzymes, your AST and ALT, are definitely going to get increased. Okay. And there will be a mild increase in my canalicular enzymes. My urobilinogen will be either normal or decreased. Fine. So if I take a hepatocellular jaundice patient, I should see all these findings. Fine. Now moving on to the obstructive jaundice. As I said, either there is an intrahepatic or an extrahepatic. I'm going to call those patients intrahepatic or extrahepatic. I'm going to call those patients as obstructive jaundice. Okay, fine. In the obstructive jaundice, if you see, first we shall look at the overall things and then we will see how to distinguish it from intrahepatic and extrahepatic. Okay. As you see, you will definitely tell that there will be definitely increase in gamma glutamyl transpeptidase and 5-nucleotidase enzyme activity. So that is going to be definitely increased. And there will be slight increase in your AST and ALT. Fine. Okay. Now, your total bilirubin will be increased. And in this, your conjugated bilirubin is going to be increased more. Fine. Your unconjugated bilirubin is going to be increased to a certain extent. But majorly you can able to see conjugated bilirubinemia. Okay. Now, what happens Prolonged obstruction of this biliary system, it can ultimately go and damage my hepatocytes. So initially the patient has an increased GGT or your 5 nucleotidase, and later the patient has an increased ALT and AST as well. So that is going to be one of the cause of my if you look at closely the obstructive jaundice, as I said, you can able to see there is a complete obstruction of my bile duct. So whenever I have a complete obstruction of my bile duct, so what happens, my conjugated bilirubin is not going to enter into my gastrointestinal tract. So once it is not entering, I'm not going to get any stercobilin, so my feces is going to be pale, isn't it? My feces is going to be pale. And what happens, this excess conjugated bilirubin is going to enter my bloodstream. It is going to get excreted into my kidney. As I said, conjugated bilirubin is water soluble. That is why initially your unconjugated bilirubin is not water soluble, it is lipid soluble. To make it water soluble, we are glucuroniting it, and now it becomes water soluble and it is easily excreted into our urine. So what happens in obstructive jaundice is the urine becomes darker in color. So your feces is pale, and dark urine is one of the characteristic sign of obstructive jaundice. And one more thing you have to look here is, in case of an acute hepatocellular damage, you also will have an increased prothrombin time. In case of a chronic hepatocellular damage, you will have hypoalbuminemia. Your albumin level will go down. Hypoalbuminemia. Fine. So if you take an overall look at what happens in jaundice, what happens in each type of jaundice, it will be very easy for you to correlate with the MCQ. So most of the time your enzymes will give you a characteristic diagnosis, or sometimes your syndromes, they'll ask you some simple questions, or they can twist and turn with this. Once you know all the concepts, it will be very easy for you to identify which type of jaundice it is. So thank you for watching this video, and I hope this video was helpful, and if it is helpful to you, please share with your friends. Thank you.